Awareness Month and going into March, which is Women's Month. So napakasakto lang na pag-usapan natin ang ating KASUSO. This is about breast cancer. Our topic for today is about breast cancer. And we're fortunate to be joined by Dr. KENNETH SAMALA. He's an active consultant of the Manila Medical Center, who is also a medical oncology fellowship ng UP-PGH. He was an incoming thoracic oncology fellow at Cross Cancer Institute of Alberta, Canada, sir. And of course, Miss ANTOLIN. She's a volunteer and a KASUSO trustee since 2009. She's a housewife and a mother of 3. Siguro you want to start, Miss AILEEN, you want to introduce first, ano po ba yung organization niyo, yung KASUSO organization?
Okay, thank you. Maraming salamat po sa invitation. So, ano nga ba ang buong pangalan ng aming organization is Philippine Foundation for Breast Care. Dahil napakahaba, ang hirap bigkasin, such a mouthful. Merong nagbansag sa amin na, ba't di na lang kayo maging KASUSO? Kasi may kapuso, may kapamilya, KASUSO na lang kayo. So it's stuck. So finally, naging KASUSO Foundation na lang kami. Kami po ay, I'm sure you've heard of a lot of breast cancer support groups. We're unique in that we are based in a government hospital in East Avenue Medical Center. We began in 2001. We were founded by the head of the Department of Surgery ng East Avenue noon, si Dr. Florentino Doble. Kasi nagkakaroon na ng mga dada-diagnose ng mga breast cancer patients, pero wala silang mapuntahan. Wala silang suporta. And we're finding na nawawala na lang sila after na ma-biopsy, after na ma-diagnose, nawawala na, hindi na nagtutuloy ng treatment. So sabi ni Dr. Doble, why don't we create a support group? So we started as a small group lang, and then eventually, nung dumadami yung pasyente, nagkaroon ng need for a breast care center. Kaya lang, hindi to part ng plantilla ng hospital. Walang funding for creating such a center and wala din funding for staffing. So we took it upon ourselves to operate the breast care center of the East Avenue Medical Center from 2004 to 2015. That experience opened our eyes to the journey of a breast cancer patient. So from the community where gumagawa din kasi kami ng mga advocacy seminars na, and then we do breast screening of women, naididiretso na namin sila sa hospital so that magtuloy-tuloy kasi it doesn't make sense. Naghahanap ka ng bukol, tapos hindi mo alam kung saan mo sila dadalhin. So parang naging na-cover namin the whole 9 years of the breast cancer journey ng pasyente from the community, na-navigate na namin papunta sa diagnostics, eventually surgery, and then treatment until surveillance. So, yun yung naging experience namin. Naintindihan namin ngayon how the system works, and at the same time, ano yung pinagdadaanan ng pasyente. Back then, hindi pa uso yung word na patient navigation. Pero hindi namin alam, yun na pala yung ginagawa namin from 2004.
Oo, napaka-importante nun, na naintindihan natin yung journey ng isang pasyente na may breast cancer. Doc Kenneth, pag-usapan naman natin yung in the Philippine context, bakit mahalaga na usapin ang breast cancer? As far as I know, we are the #1 in Asia. Not a very good number, no? Sometimes we like it when we're #1, but not this time.
Yeah, so that's really one of the main challenges here on oncology or cancer treatment in the Philippines. We do have the highest number of cases in the Philippines. And we were discussing a while ago ni Mama AILEEN, even patients that eventually die from the disease, medyo mataas yun sa Philippines. And I'd like to think that this is definitely due to several factors. No? Admittedly, majority or a lot of our patients are diagnosed late. I'd like to think na minsan it can be partly cultural. Filipinos in general have very poor seeking help behavior, meaning matiisin. And that is a very Asian, that's a very Filipino concept, very cultural, no? Minsan sabihin, masakit na, may nakakapa na, takot.
Ayaw mo.
Or hindi na lang, titiisin na lang. And then,
at saka alam kasi na mahal. Mapagamot.
In fact, ang datos ng DOH, 6 sa 10 Pinoy na namamatay ang hindi nakakapunta sa ospital. are not even able to go to a doctor, see a doctor. Kasi nga mahal, prohibitive cost.
And when you look at the bigger context of things, diba, when we were in med school, we were talking about the social determinants of health. Diba, iniisip namin as doctors, concerned ka lang sa gamot, doctor. Pero minsan iniisip mo, magpe-prescribe ka ng gamot. Pagbalik nun sa community sa bahay nila, kaya ba nilang bilhin yung gamot? May access ba sila sa gamot? So we were taught to think of the other factors that can actually contribute to why our patients are not getting any better. So ang malaking factor na po dito is really like yung access to medicines and kung available ba or in the first place can they afford the medications.
Gusto ko yung nabanggit kanina na kasi kailangan ng early detection. O, ito yung parte na lahat po tayo ngayon dito ay magpa-participate. Kasi advocacy natin to, di ba? Kailangan ng early detection. At hindi lang pang babae, dapat pati lalaki, marunong mag-detect ng breast cancer.
Yes.
Ano yung sinabi mo kanina, ma'am, habang
Meron kaming joke among ours na kapag kami mga lalaki na interesadong matuto kung paano magsalat ng suso, siniswear in namin sila, sinasabi na, yes, somebody's raising his
swearing
hand.
in tayo, mama?
May swearing in po. Ang tawag po namin sa kanila, breast roving officer. So sinasabi namin, do you wanna be a bro? So meron po bang mag-volunteer na maging bro dito?
At kapag nagkaroon ng breast cancer ang misis nila,
Dapat ang sisingin si Mister. Kasi siya dapat ang unang nakaalam.
So ngayon, mag-demonstrate po ba?
Okay.
So, ito ang tinatawag nating
Breast self-exam. Sa ngayon po, sariling salat po muna tayo. Ano po mga sir? Mamaya na po ang swearing in, okay? Ayan. So, importanteng aspekto po ng sariling salat, inspection. We're finding that ang karamihan po ng kababaihan, ang tinitignan lang sa salamin hanggang dito lang sa mukha. Hindi po sila familiar kung anong itsura ng sarili ng suso. Kung kaya nga pag may problema, hindi nila to napapansin. So, importante po yung inspection. So, may tinuturo kaming mga posisyon na ginagawa para lumabas yung ibang mga symptoms. Kasi yung iba, pag ginawa mo itong mga posisyon na to, like, ang common signs and symptoms, Doc, can you help me? Signs and symptoms ng breast cancer, Doc, ano po ba?
Right, so na-mention ni Miss Aileen yung unang-unang bagay na before tayo sumulat. Tignan muna natin. So many deformities. Minsan yung may makikita kayo na skin changes or pagbabago na dun sa balat. Of course, ang disclaimer, hindi naman lahat ng pagbabago sa balat ay maano. So maganda lang naman.
Ano natin kaagad na hindi porket hindi pantay, may problema.
Yes.
Oh, yes.
Lagi naman na hindi
Di
pantay.
ba?
Ang sinasabi po namin, they are sisters, not twins. So they're not supposed to be equal in shape and look.
Right. So yun. So minsan yung pinaka-common na nakikita namin sa patients, sometimes yung nagsusugat rin sila. So yan, very makikita. Even without inspection, even without touching it, you already see na may sugat na. Pero din kami sinasabi na describe na in French is peau d'orange, which is basically the orange skin. Di ba minsan yung balat ng orange, medyo matigas na parang may indentations, open yung ano. So, pag nakakapa na ito or may nakikita ng ganito, pwede rin siyang...
Mukhang balat po ng orange, hindi po kulay orange ha?
Kaya,
Mukhang balat ng orange.
Agree. Tapos sometimes yung even, although again, this is a disclaimer, not all of yung mga inverted na nipples, no? Na pwedeng, or automatic, pwede lang siyang mag-point to a possible. Kasi, especially kung hindi inverted before. Biglang naging inverted.
Yes.
Kung may discharge, non-discharge.
Yeah, kung hindi ka naman nagbe-breastfeeding, tapos may discharge, whether tubig, or milky, or lalo na kung bloody. But again, hindi ibig sabihin kapag may discharge, breast cancer na agad. Lagi tayong may disclaimer na hindi lahat ng binabanggit naming symptoms ay nangangahulugan na may cancer ka na. Sinasabi din po namin, hindi ko mo may bukol ka, cancer na yung bukol mo. So yun. So mag-inspection po tayo. I would like to ask everyone to stand.
Excuse ako.
Sure. Tatayo po tayo. Siyempre, imagine natin nasa harap ng salamin. Siyempre po, dahil kunwari nasa bahay tayo, nakahubad, nakatanggal ang bra kasi paano mo i-inspectionin yung sariling suso kung hindi nakaharap sa... Pero wala pong maghuhubad dito. Pakiusap po. Opo.
PG-13 tayo.
PG-13 po tayo, wala pong maghuhubad. So sa harap ng salamin, yung pong mga nabanggit ni Doc, titignan natin. So kunwari ang salamin ko ay si Doc, titignan ko yung mga symptoms na yun na wala pa akong salat na ginagawa. Sa harap, madalas po kasi ang tinitignan lang natin yung harap. Importante din po na mapakita din natin yung mga pagbabagong yon sa gilid ng suso, sa magkabila. Ang tinitignan po ay hindi lang po yung suso ha. Mula po dito, sa ilalim ng tenga, hanggang dito po sa lieg, hanggang dito po sa collarbone, sa gitna ng suso, sa ilalim ng bra line hanggang kilikili. Yan po yung mga areas na kailangan nating pansinin. Bigyan ng pansin at mamaya sasalatin. So pagkatapos po, sa harap ng salamin, itaas ang kamay. Ba't hindi po sumusunod yung mga bro? Sunod po sana yung mga bro. Hindi po kayo mai-induct pag hindi po kayo sumusunod. Wala pong induction na mangyayari. Yan. Ano po ang naramdaman, lalo ng mga girls? Diba pag angat po ng ating braso, sumusunod po na umangat yung suso. Binabanggit ko po ng malaya ang salitang suso dahil gusto ko pong tanggalin ang mali siya na nakakabit sa salitang suso. Kasi we will not have any, hindi natin bibigyan ng importansya ang isang parte ng katawan pag hindi natin ito alam bigkasin ng tama. Yun po talaga ang pangalan nito. Suso, kagaya lang ito ng mata, tenga, ilong. Tanggalin natin yung mali siya. So, dapat po susunod siya sa galaw. Yung pong signs and symptoms na nabanggit kanina, ni Doc, titignan nyo rin po yung sa harap ng salamin kasi minsan po, yung pong dimpling ay lumalabas lang pag ginawa mo tong mga arm positions na to, yung pagtaas na ganyan. Pag meron pong bukol, magkakaroon po ng dimpling minsan. So nakikita po yan pag inangat ang braso. Parehong braso. Ayan. So from this position, drop your hands pa sa harap, ganyan. Parang medyo nagbe-bend. Dahil po sa force ng gravity, dapat may parang babagsak yung suso. Hindi po malalaglag. Pag nalaglag po yung suso, pakilampot, ipalit po ulit. Okay, kasi sinasabi ay nalaglag. Okay, so dapat po, dahil sa force ng gravity, susunod po siya. Minsan po, mararamdaman ng babaeng, lalo na pag medyo malaki ang bukol, merong nag-counter sa movement. Medyo pipigilan niya yung galaw niya. Mararamdaman mo yung bigat. So, galing sa position na to, sa harap ng salamin, pwede din, kailangan din po turn to your left, and then turn to your right. Sorry po, nahihirapan si Ma'am sumunod sa akin. From this position, ilagay ang kamay sa waist. Spread up, chest apart po. Para po, yung breast magsispread. Pag may bukol po kasi, minsan, ang papansinin niyo po dito yung orientation naman ng nipple. Pag may bukol kasi, hahatakin niya yung nipple sa lugar, sa posisyon, help me with this dog. Kung saan yung bukol. Hahatak siya, kukontra siya sa galaw. Okay. So, papansinin mo kasi yung orientation. Dapat pag ginanito mo siya, your nipple should point sideways din ng konti. Dahil in-spread mo siya. So, minsan kukontra siya, may sarili siyang galaw. Minsan gigit na siya. So, from this position, subukang pagdikitin ang dalawang shoulders. Dapat yung breasts pupunta din sa gitna. Pag may bukol po, mapapansin nyo po minsan, dapat yung kabila, nasa gitna na, ito kumukontra siya. So, makikita nyo po sa mga posisyon na to, kung meron bang kakaibang nangyayari na sa loob ng suso. So, yun po yung inspection. Pupunta naman po tayo sa salat. So, meron po kami tinatawag na 5Ps. Doc, kayo po bahala mag-discuss ng 5Ps. Alam niyo po yun? Position. If you do English.
Yeah. So, yung position, of course, yung technically kasi yung nodules or mass kasi can happen. It can arise from any part of the breast, no?
Yes.
So, minsan nga ginagamit din namin na orientation yung orasan.
Yes.
12 o'clock position, 5 o'clock position. So, yun yung isa sa mga check namin. And of course, there are certain positions that you can do while you're doing the breast examination. Pwede mo siyang gawin na nakatayo. Meron din kaming ina-advocate ng lying
Lying
on
down.
your side.
Mas maganda po pag medyo malusog ang breast, medyo malaki na nakahiga. Kasi pag nakahiga ka, mas nasa-spread yung breast tissues At saka kasi, ang posisyon po dapat ganito. Kung kanan po ang sasalatin, ang kanang kamay nasa likod ng batok, yung kaliwang kamay ang gagamitin pang salat. Kasi para mas systematic tayo, mas maayos ang gagawin pagsalat. Pag sa kabila naman, lipat naman sa kabila. So, pwede pong nakahiga, nakaupo, or nakatayo under the shower. Mas madali kasi pag naliligo ka, syempre nakahubad ka naman na, gawin mo na lang ang breast health exam. Ano pa ba yung posisyon? Binanggit ko na kanina, yung perimeter, hindi lang po yung suso ang sinasalat, pati itong mga areas na to hanggang ilalim ng suso. Tapos the other P, pressure. Hindi lang po tayo, ang goal po ng pagsasalat, naghahanap ka ng bukol. Pangalawa, to become familiar with the feel of your own breast. Kasi pagka lagi mo itong ginagawa, alam mo na pag may nagbago, especially when you're doing this every month. Perimeter, pressure. Ang ginagamit, hindi po palad. Hindi din po dulo ng daliri. Kasi pag bukol yan, halimbawa may bukol na malaki, pag ganito lang ang gagawin mong pagsalat, lalo na kung movable yung bukol, gagalaw yan, hindi mahuhuli ng daliri. Versus pag ginamit mo yung finger pads, ito po. Pag ginamit mo finger pads, mas equal ang pressure na ma-apply mo, mas malawak ang area na makukover, mas madali po ang pagsasalat. So ang ginagawa po namin technique, halimbawa ito po ang suso, unang hagod mo, surface lang. Kasi may mga bukol na nasa surface lang. Pangalawang hagod mo, medyo maladiin na yung regla. Paano ito pag irregular?
Regla yung isang kababaihan, pipili na lang po tayo ng particular day of the month na I think
For menopause women.
So pipili na lang tayo.
Ang sinasabi ko po to, sa mga menopause women, ang madaling tandaang petsa para sa mga babae, araw ng sweldo ni Mister. Yun. So gawin mong reward kay Mister, araw ng sweldo ngayon, salatan mo ako.
Paano kung may PCOS?
Yung mga irregular. Ang tinuturo ko po ganito, halimbawa ngayon, ikaw ay irregular, wala kang regla this month. Dahil nandito ka, gawin mo na muna. And then, next month, pag hindi ka pa rin niregla, anong petsa mo ginawa ngayon? 27. Next month, 27 mo rin gawin. Pero suddenly, nagka-regla ka. Next month, yun pa rin day 10. Gawin mo pa rin yun. Kasi importanteng rule doon yung day 10 rule. Na hindi ka pa under the influence of the hormone, hindi masakit, mas madaling magsalat. So yun po yung mga points na dapat nating tandaan. And I hope nga po na maalala nyo po ito at i-share nyo po sa inyong, sa mga females, sa inyong circle. And of course, men. Because men can have breast cancer too. And sa amin po, i-encourage namin that men would also join the conversation kasi ang lakas po ng influence ng mga kalalakihan kapag sila mismo ang nagsalita at nagprotekta sa kanilang mga kababaihan sa kanilang circles.
On the average po, so ngayon establish na natin na kaya naman palang ma-detect kahit sa sarili mo pa lang, early self-detection ng breast cancer. Anong pinakabata nating naging pasyente?
Sa amin po, from our experience sa East Avenue, 19 years old ang
19 years old na breast
pinakabata.
cancer na. And on the average, ilan ang porsyento ng lalaki na nagkaka-breast cancer?
From the time I was exposed to breast cancer advocacy from 2009, 3 na po ang nakilala kong pasyenteng lalaki na under the East Avenue Medical Center. And ang malungkot po, pag ang lalaki na nagkaroon ng breast cancer, yung early stage na kinoconsider sa babae can be the cause of death for men. That factor, Doc, hindi ko pa masyado naintindihan bakit.
So hindi sila kasing dami, pero deadlier. Mas taas ang risk for men.
Parang they tend to, mas naging agresibo yung type of cancer that they experience. And yung sa percentage, usually it's less than 1%. So, of course, there is still that possibility, although it's not very high. But when you think about kasi all the breast cancer cases, pag yung less than 1%, minsan parang compared to other cancers, medyo malaki. And siguro i-add ko na lang din. So what to do next? So ginawa na natin yung sariling salat ng suso, we followed it, and may nakapa tayo. Again, it's not 100%, no, na it's breast cancer or it's cancerous. Especially kunwari, may mga patients kami na mga kababaihan na younger age group, although we see younger patients now. Common yung fibroadenoma na tinatawag. No, it's a benign nodule. Some patients gusto nila patanggal, so they just give up, they just let it stay there. So what to do next? Definitely, if you feel something that's different, no, seek consult with your doctor. So we can verify. And again, nothing beats yung peace of mind eh. Kunwari, nagsalat ka, tapos may nakapak, tapos hindi, again, no, bilang Pilipino, hindi, wala lang yan. So, baguhin natin yung ganung type of health-seeking behavior. No? Kung may nakapak, kung may napansin, pa-check up. Kung hindi, edi, di ba, malaking ginhawa sa loob.
And it's also important na tandaan na wala pong gamot na nakapagpatunaw ng bukol. Kasi kadalasan narinig namin po sa mga pasyente, uminom po ako ng herbal medicine para matunaw ang bukol. Or nag-seek ako ng alternative medicine. Hindi po namin ina-encourage yun kasi from our experience, ang dami po namin pasyente na unang nag-seek ng hindi doktor, nung malala na at saka papunta sa doktor para magpagamot.
Siguro tingnan po natin siya kung sa next step. We have about 27,000 new
In 2020 yan.
breast cancer patients. Isipin niyo yung 27,000 new cases in
And
a
imagine
year.
the scenario there. That was the time of the pandemic where naka-lockdown ang lahat ng tao, napakahirap pumasok sa ospital. So these were the lucky ones. So you can only imagine, yes, you can imagine now, ilan yung hindi nakarating.
And then of that, about 9,000 would die.
Died.
About 9,000 died that same year.
Yes.
So saan ang problema? Kulang sa pondo? Kasi it's treatable, kayang ma-detect. Bakit ganun pa rin yung scenario? Yung 27,000, ang bilis nating bitawan yung ganung numero, ano? Pero if you divide that into 365 days in a year, you would have an average of what? Almost 200 something in a day. Ganun kadami ang nagkaka-breast cancer.
Yes.
So, saan po yung nagiging problema? Pondo po ba ang pinakamalaking issue dito?
Maraming factors. Unang-una, for a country that's supposed to have a bigger number of breast cancer cases, first step natin, diagnosis sana. The reality is, iilan lang ang mammogram machines sa public hospital setting. Karamihan ng mammogram machines nasa private hospital. And World Health Organization recommends that a woman 40 years old and above should have mammogram every year. Eh hindi naman dito afford ng ibang mga pasyente, especially if you go to the private setting. Kasi wala ngang mammogram sa public hospital. Ang ratio nga po is 5.5 mammogram machines in a country with 7,100 islands, serving 100 million population. So you can imagine yung disparity. Number one yun, access to diagnostics. Pangalawa, the cost of diagnosing through biopsy. Mahal din. Magkano biopsy ngayon, Doc?
Yeah, so depende pa po yan kung saan ibabayaran natin yung equipment, yung facility, yung doctor. So I guess yung we had a very good conversation recently sa AILEEN prior to this. At the end of the day, parang sa tingin namin, it's really access. Access to diagnosis, access to medicines,
Yes.
access to treatment. So yun yung we feel na yun yung missing piece.
I-correct lang pala natin yung math, 27,000 is 73 new patients, new cancer patients per day. Or that's like 3 patients kada oras.
Yes. See. When you talk about statistics, yan yung estimate na pumasok sa healthcare system. Ang dami pa rin.
na tayo ngayon. Sabihin may 3 nang na-detect.
Yes.
Na breast cancer patient.
Ito yung nakapasok sa healthcare system. Hindi pa kasama sa numero, yung nasa komunidad, nasa bundok, nasa pinakamalayong probinsya, nasa mga isla, na merong mga issues na hindi nakakarating sa ospital. Hindi man lang nakikita ng doktor.
And this could be, someone's mom, aunt, or lola, sister, diba? So when you look at it from that perspective, we know that we have a very huge challenge ahead of us when we talk about cancer. cancer, and in particular breast cancer in the Philippines?
Sometimes people feel na yung breast cancer or cancer in general, it's a life sentence. Pero ang dami na rin technological advances ngayon. In fact, during the cancer summit the other day, we were talking about it. Si Dr. Carmela Caballero, she was saying na half the time for breast cancer, hindi mo kailangan ng chemotherapy. And it shocked me kasi parang sa ating Pilipino, default mo kaagad. Pag may cancer ka, mag-chemo ka. Can you discuss about it?
Yeah, so whenever I have parang bagong pasyente sa clinic, isa yan sa mga bagay na in a way, as an oncologist practicing even in a country like Philippines na third world, we're very happy na pag sinasabi natin na, kung paano natin gamutin yung cancer 20, 30 years ago, sobrang ibang-iba na po. It's so different how we treat cancers nowadays. Probably before, pag na-treat ka, na-diagnose ka in the 90s, in the 80s, sasabihin lang sa'yo ng doktor, mag-chemo ka. Kumalat, mag-chemo ka ulit. Kumalat ka, mag-chemo ka lang ulit. So right now, since I'm Dr. Caballero, we have a lot of options. And siguro, I'll use definitely breast cancer as an example. Chemotherapy is no longer an automatic option. Meron tayong mga hormonal therapy, may targeted therapies na. So depende po ito dun sa breast cancer subtype ng patients. And you know what, I have patients na for example, yun yung common story, no? I have patients na parang nag-undergo ng chemo a few years back, and unfortunately may bumalik. Tapos nagkataon na yung breast cancer subtype niya, pwede siyang gamitin ng targeted na tablet lang. So, unang bungad niya pa lang sa akin, Doc, ayoko mag-chemo. So, kung 20, 30 years ago yun, sasabihin ko sa kanya, wala kang choice.
Walang ibang option.
Kailangan mo mag-chemo. But now,
ngayon, ang daming
sabihin ko sa'yo, I understand and I think eligible po kayo to receive this start. Imagine a pill, tablet lang po siya na iinumin lang ng pasyente. Siguro magkikita lang po kami ng patient once a month just to check the labs. Pero basically nasa bahay siya taking the meds.
Ang DOH natin has also invested in medicines for cancer. But right now, I think it's just the IV. IV na
Meron na rin
yung
subcutaneous,
injection.
Yes. Meron naman. Meron namang provision for, especially under the CSP side. Ibig sabihin cancer support, medicine access program. So yun. Meron, in principle, meron po tayong free chemo, pinakasimpleng term. Free chemo for cancer patients under the DOH program.
So it's a universal healthcare.
Yes, this is under the universal healthcare. So meron po tayong programa. Wala po talaga dapat ikatakot ang mga pasyente na hindi kami, wala kaming tsansa, wala kaming hope, kasi wala kaming pera. Meron pong available. Isa din po yun sa challenges. Access, also information dissemination. Ang daming mga kababayan natin ang hindi alam na libre pa lang magpakonsulta sa public hospital. Madalas ang mga inquiries namin, ma'am, mayroon akong bukol, saan po ako magpapacheck up, wala akong pambayad. Libre po ang konsulta sa lahat ng public hospital sa buong Pilipinas. Madalas pong sabihin yan, ma'am, paano po kung ma-ooperahan ako? Libre po ang opera, lalo na po kung kayo ay PhilHealth member. Yun po ay isa sa mga benepisyo nyo. Libre ang inyong surgery. Ma'am, paano po kung magpapakimo? Mahal po ang gamot. Ganito ang cost. Meron po tayong free chemo program sa ating mga pampublikong hospital. Hindi lang po talaga alam ng kababayan natin na meron tayong mga ganitong programa.
Even radiation therapy.
Even radiation therapy meron din.
And just to add though, it's also a common parang experience that na-encounter ko sa clinic. No? Sometimes I would tell patients, madiscuss na namin yung diagnosis, ito yung gamutan. Minsan may kita mo sa patient na talagang pinag-uusapan niya pa lang yung cost, umiiling na ina-offer ko na. Sabi ko, okay, if hindi natin kaya in a private setting, if you are open to it, I can refer you to So usually I just give them an endorsement letter. And I would say a lot of patients already benefited from the CST map naman po in fairness. No? So, yung agam-agam ba nila na sometimes kasi yun yung reason, no? And tatama po, no? May mga patients na nakita ko once, tapos din-discuss ko yung diagnosis, sino bumalik kasi yung cost na takot na. So kung, sabi ko nga, for me as an oncologist, as a doctor, yun yung pinaka masakit for me kasi na-catch ko na siya eh. Sabi nga ni Ma'am AILEEN kanina, no, sometimes yung data ng 2020, that's 27,000 during the pandemic. You wonder, ilan kaya yung hindi nagpunta sa hospital? So, for me, kapag na-catch ko na sila, ibig sabihin ito na yung talagang opportunity. So, ayaw mo na silang mawala.
Yes.
So, ako very honest ako, sabihin ko, very open ako, hindi siya issue for me. So, kunwari pag alam ko na medyo magiging challenge for me. Kasi ang important sa akin, saan ba tong patient na to makakatuloy ng treatment niya? So, whether it's with me in private or if I can refer them to a public hospital, I think a lot better. Kasi at least kampante ako na mag-direction na rin.
Yes. Isa rin sa challenge natin sa ating mga kababayan, yung health literacy. So, health seeking and health literacy, they go hand in hand. We found this, we just came from Bacolod. We had a partnership with the Bacolod City government where we wanted to provide free mammogram sa mga kababaihan with breast issues in that area. Nakausap namin ng isa sa mga oncologists doon, and he said that, especially for those in the far-flung areas of Negros Province, nasa dulo-dulo na ang hirap pang pumunta, pagka kasi na-biopsy sila, ang pag-intindi nila na opera na sila. So pag tinanong mo, ano na po, may bukod po ako ma'am, na opera na ako, ang understanding nila, pag natanggap na nila yung result ng biopsy, tapos na. Yung kailangan nating ipaintindi sa kanila na hindi pa natatapos dito yung iyong journey. Meron ka pang dapat gawin. And yun nga po, ugali nating Pilipino, hindi tayo kumukonsulta ng doktor hanggat hindi tayo nararatay. At kung kumonsulta man tayo, pag binigyan na tayo ng reseta, akala natin tapos na. Hindi natin habit yung regular consultation na bumabalik tayo sa doktor para magpa-follow up. So ito din po yung mga bagay na gusto din namin iparating. More than just providing them with access to treatment, medicines and diagnostics, yung mga information na kagaya nito, it takes intentionality din kasi naintindihan natin our doctors, our clinical staff are already overwhelmed
Yes.
with the taking care of patients in the hospital. Hindi na nila to kayang isa-isahin pa, and it takes patient support groups like us to be able to really put in time to explain to them na ito yung journey mo, ganito ang mangyayari, ito ang dapat mong asahan para maipaunawa sa kanila. So mahalaga po yung partnership ng medical community and the patient support group na para matulungan yung pasyente na matuloy-tuloy niya yung kanyang lakbayin.
And kunwari, forum such as this, no, I would imagine yung impact niya. Kunwari, I'm watching on my phone. Diba, parang initially wala akong idea about how kung pagsalat or anything. So, at least kung may na-touch tayo ng isang lives, may na-convince tayo ng isang person to seek consult or naging aware siya sa gagawin natin, definitely, that's a very huge win already.
Sa ngayon po, parang the DOH has about, I think, 1 or 1.5 billion budget for cancer.
For cancer control law.
Ano po ba? Sasapat po ba yun? Are you asking for, of course, we always ask for more, ano? Ano po ba yung medyo realistic na?
Realistically speaking, pag sinabi mo kasi 1 billion for the cancer control law, that covers all other cancers, hindi lang breast cancer. And from my experience sa breast cancer, kasi meron kasing mga pasyente, at least dalawa lang dyan ng early stage. Most of them may need more treatments. Kasi meron tayong tinatawag na recurrent, meron tayong tinatawag na metastatic breast cancer or advanced breast cancer, which means that this woman, after having been diagnosed, may spend her whole lifetime being in treatment. So pag yun ang iisipin mo, sa ilang pasyente lang, I'm only speaking from the breast cancer point of view, kukulangin yun. If we are going to follow all the protocol of treatment for cancer.
And that budget po kasi, it's also allocated for screening. I think they also allocate for screening, for diagnostics. So it looks huge, but when you look at it parang in a more microscopic level, pag breakdown mo siya, yung mapupunta lang talaga for treatment is definitely a fraction. Okay.
In fact, kung ibabangga mo siya dun sa 9,000 na deaths noong 2020, parang I'm sure a lot of those could have been prevented
Yes.
kung mas malaki yung budget ng gobyerno para dito sa cancer
And also you
nila.
have to remember that yung 1.5 billion could also go to building the infrastructure. Kasi wala nga, like I said, hindi lahat ng public hospitals are built to address diagnosis, treatment, etc. etc. So makakatas pa rin yun doon sa building infrastructure.
Ano ang realistic na dapat yearly budget? Or ano yung panawagan ninyo?
Mahirap
Yung
kung masabi yung
double
exact.
triple it? Ano ang...
I think the most in an ideal setting really is talk to different stakeholders.
Sana.
May consultation.
May ongoing consultation.
Ongoing consultation. And it's a moving target kasi siya for me.
Dapat.
I think it's a moving target. Like for example, year in and year out, we have that new cases kasi yung nire-report natin
Yes.
sa incidents. But yung new cases kasi na yan, next year mag-reflect na naman sila.
Yes.
And
And
yung mga
also,
buhay pa nung
naiiwan
last
yung
year.
kasi binibilang natin new cases. Nakakalimutan natin may ongoing pa.
Ongoing. Yes.
So yung 27,000 noong 2020, hindi na nabilang yung how many were ongoing patients then. So, mahaba siya, mahabang usapin, maraming factors. Ang maganda sana dito, yung meron sanang ongoing consultation with the stakeholders so that every cycle or so, na-measure natin where are we failing in the program, what do we need to add in, saan tayo nagkukulang, more or less, in a year, to cover the new cases. Siguro ang pinaka-practical na masasuggest ko, dagdagan ang universal healthcare coverage for breast cancer. Kasi right now, 100,000 for breast cancer in a lifetime. In her lifetime. Metastatic breast cancer. Yung 100,000, kulang pa yun sa surgery.
Right.
Kulang yun sa, ang daming kailangan gawin. So, siguro yun yung pinaka-practical, dagdagan yung coverage to include diagnosis. Kasi hindi naman covered ng, like, kung magpapa-mammogram siya, hindi siya covered ng universal healthcare. Kung magpapa-biopsy siya, hindi siya covered agad-agad ng... And there not a lot of hospitals can be, na magagamitan mo ng PhilHealth. Kasi nga, meron tayong history from the pandemic na maraming hospital ang napasok sa PhilHealth issue.
So yun yung ironic, You can only avail ng PhilHealth pag sure ka na breast cancer ka. Pero yung proseso mo to get there,
Yes.
yung mammogram mo, yung biopsy mo,
Yes.
hindi siya covered under
Yes.
PhilHealth sa ngayon.
Maybe there's a disconnect or parang
Yes.
fragmented pa siya na
So,
hopefully
kailangan may sakit ka na talaga bago
Yes.
walang preventive.
Yes. Merong mandate, World Health Organization created a parang subcommittee to address breast cancer. This is called Global Breast Cancer Initiative. And sila yung nagsiset ng standards for how do we attack, kasi sabi nga nila, in a few years magkakaroon ng epidemya ng cancer sa buong mundo. So they needed to create initiatives para ma-address ito. Ang mandate po dito dapat within 60 days na-diagnose na yung babae, and within 30 days from diagnosis, matreat na siya, makapasok na siya sa treatment. The problem is, wala tayong screening program. I mean, wala tayong, di ba mayroon tayong cervical screening, gano'n. Hindi siya programmed activity ng DOH. Kung meron tayong gano'n, siguro at least maaga nating makakapture yung early stages. Mas madali nating sila maipasok sa healthcare system, mapagamot, etc. etc.
Sana yung pondo mga nasa 5 billion.
Sana.
Plus.
Plus. Higit pa doon.
Although I became part of the DOH group po kasi na basically DOH chat PSMO to come up with, and another group to come up with guidelines, Philippine guidelines for screening. So, I think baka nandun na tayo sa direct. Baka papunta, kasi parang they wanted muna data as basis for putting up with the screening program. So, at least we're going to that direction already. But hopefully yun nga, hopefully it will come soon. And hopefully ma-fund din para at least kasi I became part of the colorectal screening, so I know some of my colleagues work for other types of cancer as well. And I think, at least the direction is going there.
Pahapyawan ko lang, there's an ongoing discussion sa DOH on whether we should use yung IV or whether we should use yung subcutaneous na injection. Ano po ba yung difference ng dalawa? And ang isang issue kasi nun parang mas pricier daw yung injection. Pero if you compute it, kung magkano yung kakailanganin mo, depende sa weight, depende sa ibang factors, parang mas ano naman siya, mas mag-even out.
Yeah, we were discussing in Miss AILEEN, sometimes nga kanina parang, when you look at it at face value kasi, the injection, so basically po, ang issue dito is like, they're both the same medications, iba lang po yung preparation. Isa po, yung IV, yung typical na chemotherapy na pinapadaan sa swero, may swero, papadaanin sa tube, tapos sa balat, sa ugat. And then meron po kasi yung preparation, naggawa na ng preparation, na i-inject na lang yun. So, pero same na yun. Mas mahal yung in-inject lang kasi may bagong technology, para at least injection.
Less invasive.
Mas mabilis ibigay.
Mas mabilis.
When you think about it, at face value is more expensive. But when you think about consumables, meaning yung nagamit mo na swero, yung nagamit mo ng mga gamit, the supplies, the manpower to do that, tapos
ilang milligrams yung kailangan mo.
Oo, ilang milligrams. Ito, fixed dose lang siya or same lang. Tapos I think, sabi ko nga, pag when you think about it, inisip mo lang yung yung tawag dito, how can yung time na magsisave mo?
Yes.
Basically po, for example, if you give the injection, para po siyang vaccine.
Yes.
So basically inject. So, sabihin natin kasama na yung preparation from the vial and everything. Siguro sabihin natin 5 to 10 minutes. In 1 hour, you're makaka-cater ka ng mga 5 to 6 patients in 1 hour. Kapag yung sa usual na IV form, siguro 2 pasyente lang yung makikater mo in an hour.
In an hour.
So, kung ako ay parang kunwari, in a business perspective, mas marami akong makakater na patient doon sa injection. At face value, mas mahal siya, pero actually, I'm actually saving more. And sabi ko, how can you put a price on the time?
Yeah, at saka may factors din na, kasi pagka ang pasyente, hindi naman yan forever. Again, only 2 patients will be qualified to undergo one kind of protocol as a chemo treatment. Karamihan ng pasyente, nagpapalit siya ng gamot. So pag finactor in mo yung mga cost ng pabago-bagong gamot dahil hindi mo kayang ibigay yung mas mahal na gamot versus kung binigay mo agad yung targeted therapy na nag-work siya agad at on instant na binigay mo siya, pag pinagsama-sama mo yung cost nun, parang ganun din eh. Alam naman natin that majority of our patients seek financial support from the government. So, kung itong pasyente, patient A, like the case of Medellin, kasama ko po ang isa sa mga beneficiaries namin sa KASUSO Foundation. Siya po ay stage 4 patient. 3 beses pong bumalik ang breast cancer niya. 3 klase ng gamot po. Halika, Medellin, samahan mo kami. Dito. Ito po si Medellin. Medellin, pwede ba kitang ikaw na lang ang magkwento? Anong stage ka? Anong gamutan? Pang ilang beses kang nagkaroon ng cancer? At yung akwat.
Bali, na-diagnose po ako noong February 2020. Tapos, na-opera po ako February 2021. Then, after po ma-opera, 2 months, nagbalik po ulit yung bukol ko. Tapos, kinimo po ako July 2021. Then, 6 cycle po, tapos first na target therapy po ako. After 7 months po ng target therapy, nagbalik po ulit yung bukol ko. Now, kinikimo po ulit ako. Opo, ganun po. Bali, medyo matagal lang po yung proseso ng opera ko dahil gawa din po ng mga procedure po. Kasi ang hirap po hanapin ng ibang procedure sa mga hospital. Then Yun. Tapos ano po, yung pandemic po siya, nahirapan din po ako. Bali, nilalakad ko po yung malayo bago makasakay papuntang hospital. Ayun po, kaya medyo naging mahaba po yung bago ako na-opera. 1 year po bago ako na-opera.
Bali ngayon, 3 klase ng gamutan ang pinagdadaanan niya. Meron siyang, tapos nila yung basic na tinatawag. Meron siyang targeted therapy. Meron pa siyang hormonal, kasi yung paclitaxel. Tapos meron din siyang zoledronic to address, kasi meron siyang metastasis na. So, classic example of what a patient would go through. She's just one of at least, siguro sa 10, siya yung isa sa 8 na ganito ang magiging picture ng kanilang journey. So pag pinagsama-sama niyo yung cost na yon, it's as if you bought that pricey but working high quality medicine.
And pero sa ngayon, parang DOH is providing that already. Hindi pa. So is that something that you were asking DOH?
It's not yet part of the
PNDF. Yeah. So ang isa sa mga parang naging roadblocks namin, no. So before po kasi magamit sa formulary, so basically sa drug formulary, yung mga bagong gamot, yung mga makabagong gamot na effective at nagamit naman sa ibang bansa na marami ng pag-aaral, ang hirap makapasok sa drug formulary. So ang proseso po kasi nito, before siya ma-purchase or before siya ipasok ni DOH doon sa CSP map na programa, kailangan nasa formulary muna siya. To be honest po, ang dami na namin ina-apply ng mga gamot sa formulary, kahit na matandang gamot na, pero effective pa rin. Minsan hindi pa rin ito nakakapasok. So, yun yung isang, kumbaga, roadblock namin na alam na effective siya.
Save ng buhay.
Sana ma-expedite, mapabilis yung proseso ng formulary inclusion. Pag napasok po kasi siya doon, mandated na, or wala nang pumipigil sa DOH para i-acquire yung gamot na yun. So, yun yung isa sa mga importante, I think, na more than infrastructure, yung gumagawa tayo ng mga buildings, no? Importante rin sana yung access, yung formulary inclusion ng mga gamot at makabagong gamot. Yung na-share ko nga kay Ma'am AILEEN, no, ay nag-train ako sa US for a short period of time. Masaya, kasi nakita mo kung paano tinitreat yung mga ideal setting, no, kasi sa US. But towards, I remember mga 1 linggo pagkatapos ko nung nandun ako, in a way nalungkot ako. Kasi sabi ko, yung cancer siya kahit nasa US ka, kahit nasa Pilipinas ka, same cancer yan eh. But nabubuhay ng mas matagal, hindi sila hirap makakuha ng gamot. Technically, we're saying, swerte sila kasi pinanganak sila sa US. Pero yung nasa Pilipinas, kailangan igapang, kailangan mag-clinic, kailangan pa natin hanapin yung mga no. Well, in fact, we know that there are medications already that really works, no? So yun yung first reality. So
prevented 9,000 deaths.
At saka makikita mo yung impact nito financially, ha. Like Madeline, she could still be an able-bodied woman if we are able to bring her back to society to become productive. The sooner we treat them with the best medication, the sooner they can go back to society and maging productive. And even more, yung impact ng nanay. Kung mababalik mo siya na healthy siya, maaalagaan niya ang mga anak niya, maaalagaan niya ang pamilya niya, imagine mo kung ano magiging impact nun sa general context of things, malaki din ang magiging beneficial nun sa society, sa community.
Oo nga. Maraming salamat po, Ms. Madeline, for joining us. Siguro at this point, we can open the floor to questions, if you have questions. And then we can take a few.
Yung mga new medicines.
The microphone is over there. You can introduce yourself and then ask your question.
Yes, good morning. Ganda na sa from the Manila Times. Na-mention mo nga no, yung poll nga doon sa Philippine National Formulary sa cancer drugs. Do you think po ba isa rin po sa yung isa sa mga naging issues din why some drugs are not included in the Philippine National because the requirement of the DOH to subject these medicines to the HTAC. So, do you think po ba we have to reform again the HTAC? Pero kasi, the HTAC kasi is a requirement of the Universal Health Law. Right? So, sa tingin niyo po ba, do we need to revise the system of health technology assessment para makapasok yung mga drugs na yung mga drugs na sabihin natin life-saving? Kasi nga, yun yung sa mga reklamo din, why some vaccines were not as fast na may pasok dito or mai-administer dito because of the health technology assessment requirement.
So, but in fairness, no, I had some colleagues already. So I think they recognized that for us to truly have a very good universal healthcare system, kailangan yung access to medicine is there. So, nakita ko naman na there's already an effort. I think nag-onboard na sila nag-onboard na sila ngayon. I know for a fact one of my mentors, one of my professors, ay naging, parang hinire na siya, an oncologist. So, I think the step is going to that direction already. Because I think, baka nga, given because of what happened to the vaccine, baka medyo naisip na, oh, I think we need to hire more people, we need to streamline this, we need to make this process a lot easier.
I think the keyword is hire more experts.
Hindi lang hire more people,
Yeah,
hire
experts.
more experts talaga.
I think the direction is going there. And I hope, of course, this is, hindi naman siya instant, hindi naman siya magiging overnight, but I do hope that going to this direction will definitely makes it easier, faster for us for medicines to be included in the formulary. Yeah.
Thank you, Red. Next question.
Yeah. Good afternoon. Good morning po. Makon Araneta from Manila Standard. So, we have been talking about this cure and the availability of free treatment for cancer, or specifically for breast cancer. Pero ang nakikita natin problema rito is the lack of mammogram machines. So how do you think should this be addressed by the government, particularly the DOH?
Well, meron naman ng moves ngayon. May, like, for example, sa PGH, meron ng binibuild na cancer center which includes diagnostic modalities. So, nag-uumpisa na. Nandun na tayo. May mga public hospitals. Ang nakikita ko lang na maganda sanang matignan is huwag i-concentrate ang lahat ng effort dito sa Metro Manila. Kasi marami tayong pasyente din na nasa Visayas and Mindanao na walang available masyado doon na resources. Like, meron kaming ongoing partnership na with Negros Province na inaayos namin. Isa sa mga challenges sa Negros Province is that meron silang working district hospitals, pero walang mammogram doon sa Negros Province. They have to go all the way to Bacolod City para magpa-mammogram. So, yun yung mga challenges na sana, if at all, if it's possible, at least regional level yung provision or district level yung provision ng mammogram. Sige, doon na lang tayo sa regional level para lang ma-cover yung population within the region. Maganda sana yun.
Dapat yata isa sa call natin for lawmakers, to make sure naman na yung
May early
area of
detection.
constituency nila meron.
Hi, good morning. Raya po from ABS-CBN. Nabanggit niyo po kanina, sorry, tatay ako. Nabanggit niyo po kanina na yung challenges and problems yung sa gamutan para sa mga cancer patients. Pero while nananawagan pa po tayo ngayon sa DOH, ano po yung pwedeng gawin as of the moment para sa mga cancer patients? Kasi hindi naman po natin pwedeng hintayin. So, ano po yung pwedeng ilang? Kasi baka mamaya may mga nakikinig sa atin, baka mawalan sila ng pag-asa dahil
Panawagan sa ngayon.
Ano po yung as of now? Ano yung pwedeng gawin?
Sige, as a patient as someone representing the voice of the patient, yung immediate need, like in a public hospital setting, ideally sana available lahat ng tests, laboratory tests na kakailanganin nila so that they don't have to mag-scout pa sila kung saan para, kasi kung meron tayong programa, covered na dapat yung diagnostics and the ongoing tests na kailangan nila during the whole chemo cycle treatment nila. So, sana available na siya. Hindi siya available sa lahat ng public hospital. Parang may mga times na kailangan pang lumabas ng pasyente and make it affordable or at least at a sociable cost para naman hindi na pupunta yung pasyente sa private diagnostics, sa kung saan-saan para lang mapagawa ito. Lalo na kung ongoing chemo ka, na nilalakad mo yung iyong financial assistance sa kung saan-saan, tapos pipila ka doon, na imagine nyo po yung scenario na araw-araw, in between cycles nila, pagkatapos nila mag-chemo, pipila, isipin pa nila pag magaling na ako, pipila pa ako ngayon sa financial institution para humingi ng financial aid para sa aking laboratory. Tapos pipila sila ulit para maghanap ng laboratory or test na kailangan nila kasi hindi to available sa kung saan sila nagpapakimo. If we can make all of this available in the same place, para naman mabawasan naman yung hirap ng pasyente, mabawasan yung kanyang mga times na nasuspend sa pagpila. Kasi kawawa naman, chemo patient na nga siya pa yung naglalakad, tapos kung saan-saan pa siya napupunta para lang
Lalo pag wala po kaming, kagaya ko po, ako lang po talaga naglalakad ng mga kailangan ko. After ko chemo, kasi kasuin ko lahat yung mga bills ko. Magpapalakas muna ako bago babalik ng ospital. Pero ngayon, kailangan ora-orada ayusin na namin yung aming bill. Kaya after ng chemo ko po, kahit medyo hilo, pinaprocess ko na po. Then, ibang araw, babalik for laboratories, magpaprocess ng laboratories, ilalapit kung saan-saan po, ganun po.
Isang bagay na gusto namin sanang mailapit sa gobyerno, magkaroon sana ng courtesy lane for cancer patients man lang. Para yung mga, lalo na pag ongoing ka, bigyan sana sila ng priority lane kasi para agad-agad mabigyan sila ng assistance habang nakapila sila. Kasi alam naman natin, hindi lang naman cancer ang humihingi ng tulong sa mga financial institutions. Pero iba kasi yung case nila, mas immunocompromised sila. At saka, pag the more times exposed na nakapila, mas prone sila to infection. Yung mga ganong bagay. Maliliit na bagay, pero ang laki ng impact.
Na-realize ko lang, Miss Aileen, when we were, especially during the pandemic, ito na-realize namin yung challenges, no? Kasi parang nag-multiple, nag-triple yung challenges ng mga cancer patients during that time. Where will they go? Saan ako pupunta? Hindi ako makapunta, yung hindi ako nagtungan ni Madelina. Kailangan ko muna maglakad kasi nawala yung, may fragmented yung sa transport system, no? So, actually, noong time na we were trying to come up with parang like a command center. Of course, during that time kasi COVID was everybody was focused on COVID and we tend to forget the other diseases, no? We were thinking of actually coming up with a command center for cancer patients, basically triaging them, basically telling them saan yung location mo. Itong hospital na to ay may ganitong facilities, pwede ka dito, or ano yung pinakamalapit sa'yo. We were thinking of having that and sort of basically a patient navigation system. And this yung ganitong sistema, it can work basically from diagnosis, pwede pa nga magsingit ng screening from diagnosis to treatment to surveillance, no, na parang third month mo na, kailangan mo na magpatingin sa doktor mo. Parang may ganong system sana, may mga kamusta. So, I don't know, like, of course, it was very challenging during that time, pero some of our oncologists were actually thinking of coming up with a command center like that. So, in terms of what can we do now, I think, na-mention ni Ma'am Aileen regarding the health literacy and the health-seeking behaviors of Filipinos in general. I think talking about it, we need to talk about it more. And thank you to everyone who's here kasi ako nga pag tumingin, syempre pag may tinignan akong patient, that's one-on-one. Isa lang yung marireach ko eh. Kung ilan lang yung patient na pumunta sa akin, siguro makakwento na sa kapatid niya, pero hindi ganun kalaki yung reach. But if we use platforms such as these, the media, the print, the TV, we're able to reach more people. And sabi ko nga kanina, baka mamaya may nanonood sa atin or may nabasa dun sa sinulat na article bigla niya na-realize, ay oo nga no, parang may nakapa ako, baka kailangan ko magpatingin sa doktor. So, I think from there, the health literacy definitely is something that we can definitely work on for now, kasi at least, yung madala lang natin yung patient na nagpunta siya sa doktor. Napakalaking bagay na niya, I think, at this point.
You take the first step, it's already a big step.
Yeah.
We have time for how many more questions? Maybe 3 or 4? Okay.
Good morning po. Dek po ng Philippine Star. Tanong ko lang po kasi balik tayo dun sa mga dahilan ng sa breast cancer kasi parang meron dyan sinasabi na namamana, merong sinasabi na pag merong hindi ka magandang habits na ginagawa o sinusuot, o yung klase ng bra na sinusuot, o yung mga pagkain. Alin po ba dito talaga yung merong scientific basis, and at the same time, alin doon yung pinakamataas yung porsyento na ito yung dahilan bakit meron tayong breast cancer?
So yan yung sa risk factors. So favorite question din siya ng mga patients that I was sharing sa group a while ago, no? Especially if patients are young, sometimes they would tell me, Doc, I mean, may ginawa ba ako or may kasalanan ko ba kung bakit ako nagka-cancer? So I will always tell them it's not your fault. And a lot of patients they feel guilty and they pinaparusahan nila yung sarili na may ginawa ko, tapos sarili ko may ako. But majority of the time, I would tell them you do not do anything. No? But having said that, of course, there are risk factors, and these factors technically can increase the chances of you having, we're just talking about the causes of breast cancer, no? Siguro yung meron kaming tinatawag dyan na modifiable and non-modifiable risk factors. Sabihin yung modifiable risk factors, pwede pa nating modify, sabihin pwede nating baguhin, no? May mga ginagawa tayo na pwede mag-increase ng risk. One of them is actually very common, I think maraming nakakaalam sa smoking. So that's a modifiable risk factor. Alcohol consumption, and of course, alcohol consumption, hindi naman, if you drink yung social drinking, standard drink, that's fine. But of course, yun yung mga modifiable na risk factors. Physical inactivities, yung mga pag hindi tayo masyadong active, no?
Which also comes arm in arm with healthy diet.
Agree with the diet as well, no? So it's really lifestyle modification. But of course, there are non-modifiable risk factors as well.
Hindi kasama din yung masikip na bra.
Walang kinalaman.
Na-mention niyo po, wala.
Kasi lagi siyang nababa.
Wala. May nabasa na rin ako, I think one time, Vera Files also reached out to me kasi they wanted to debunk kasi deodorants. I had to debunk a claim na yung deodorant antiperspirant kasi malapit na. I mean, I had to debunk it, no? I had to provide them like information and provide them with sources, no, so they can debunk it. Non-modifiable risk factors, ibig sabihin, unfortunately, wala tayong magagawa dito.
Yes. Nature siya.
Age is one. Although, pinag-usapan nga natin, pabata, no? Before kasi, tama si Miss AILEEN, no? I guess when you started yung sa KASUSO, di ba? Usually sabi
kala ko kasi sakit lang siya nang menopause women. Pero as I stayed longer, the patients are getting younger, and ang nakakalungkot, yung cancer ng mas bata, mas aggressive, mas mabilis mag-progress. Sa amin sa KASUSO, we don't encourage the use of breast cancer prevention. Kasi hindi mo mape-prevent na magkaroon ka ng cancer. Unlike cervical cancer, there's a vaccine. Meron kang mga pwedeng iwasan para hindi ka magkaroon. Pag breast cancer ka kasi isa sa mga risk factor doon, babae ka. Hindi mo na mababago yun. Because the same hormone that gave us our female characteristics puts us at risk for breast cancer. Aging, like yun nga, hindi discuss. Like yung early menarche, hindi mo na mababago na maaga kang nagregla at late ka na tapos magka-regla, late ka na menopause. So that has also something to do with your hormones. So a lot of the factors surrounding breast cancer is hormone related. Pero kung ipipinpoint ko exactly what caused breast cancer, wala pa po talagang mapipinpoint na exact cause nun. It's all genetics.
Yeah. And mas common pa rin po na nagkakaroon ng breast cancer. I mean, walang family member. Now, when I ask patients, walang history, walang family member. Although, kapag nagkakaroon na ng family history or nakikita, ang tawag namin nagka-cluster na, clustering of families na nagkakaroon ng cancers, doon kami nagpapaisip na probably there is a genetic mutation. I think doon yung parang naiisip ng mga tao na baka naman. I'm sure you've probably heard about a few years back, Angelina Jolie. The Angelina Jolie effect. Yeah. So what happens? So to put it simply, Angelina Jolie doesn't have any type of cancer.
Wala.
But her mom, the sister, her maternal aunt, I think. So medyo may clustering. So these are the people that most probably will recommend doing the test, and she did that test. It's a BRCA mutation test. It turned out she has the mutation, and that puts her at risk for developing breast cancer.
Yun sa ating setting kasi unang-una yung geographical challenges natin we're 7,100 islands, separate. Tapos ang daming factors hindi pa ready yung healthcare system natin to adopt such kind of drastic siya masyado.
Yeah. Siguro what I can see is probably we can definitely start yung isang aspect of treatment, isang aspect of managing breast cancer in general, yung screening. Definitely a community-based screening because grassroots level.
Yes. At saka yung early detection.
Early detection, baka yun yung pwedeng makontribute ng mga LGUs. It's not as costly as definitely providing the medications, but I think it's a good start. And I think may isang LGU in here, and the Metro that's already nag-start na silang community-based cancer. So baka kung sa LGU level, baka probably we can start from that early detection screening, and then baka mas national level or regional level at least yung treatment.
Parang ang nai-imagine ko, di ba pagka panahon ng dengue, meron tayong dengue program. So if siguro kung ganun kasigit yung campaigns to increase awareness for breast cancer all over the country, parang for us kasi minsan nararamdaman namin nagiging flavor of the month kami tuwing October. So sana kung merong increased awareness throughout the year, na hindi lang siya pang October, siguro maganda yun. Kasi lagi nga namin sinasabi, sana naaalala lang, hindi tayo nagiging flavor of the month lang. Sana ang awareness ng tao tungkol sa breast cancer 24/7, 365. Kasi hindi naman tuwing October lang nagkaka-cancer ang pasyente. Yun, ganun siguro.
Another question na po. Yung again doon sa treatment po, considering na fairly new nga po yung injection, ano po yung mga side effects niya? Kasi we all know yung sa chemotherapy, yung mga ibang side effects na. Dito po kaya, meron din po kaya?
Meron pa rin naman, oo. But the thing is, ang maganda kasi dito with targeted therapy, so definitely the side effect profile or yung mga side effects, hindi na natin nakikita with the usual targeting with the newer medications. I think that's one of the advantage of it. Before, majority kasi when we think yung typical picture, I'm sure si Madeline can definitely attest to this, definitely yung mga medications na chemo that we usually give our patients, na vomiting, the nausea, yung madaling mapagod, yung hair loss, di ba? It's very, very, very hard, no? Very challenging for patients to go through. Ang napansin ko when I give the targeted therapies, definitely wala yun the hair loss, the nausea. Probably there's a bit of nausea, but not as much. Hindi sila, may mga patients ako na given yung mga targeted therapy, they're working. Basically, especially yung mga injection, right? I remember I have a patient before na
recovery period mabilis.
Yes.
Halos wala yata.
Halos wala. Minsan, joke ko nga sila, sabi ko, nag-chemo ka ba talaga? Parang pagka-inject ko sila, uwi ka na, nag-malis ka na, parang uwi na. So definitely, the quality of life is a lot better.
Yeah.
So kung meron man, sometimes because it's an injection, yung sa injection site, yun yung mas common na sinasabi nila. But of course, it's very
Very minimal.
very
Manageable.
manageable side effect.
Other questions? Yes, sir?
I'm Hector Villacuerta of Plaridel. Yung challenge talaga ng may sakit, especially cancer or breast cancer, is the money involved. If you're in Manila, gising ka ng maaga, punta ka sa Senado, wait for your turn, and then maybe you get a letter of guarantee up to 10,000, 20,000. Or after that is consumed, you go to PCSO or go to your congressman, mayor. I think from this lecture, we can have a small group that will find a more creative way of funding the requirements under the universal health care or under these congressional dole-outs or PCSO. Because in other countries, from birth till death, walang gastos ang health cost. Eh, ang problema, if you are cancer-stricken in a secluded island, it's almost a death sentence, whether it is cancer or a simple dengue or whatever, because of the lack of access to medical expense. So I would suggest, even from the point of view of law, that private corporations and individuals can make abono and make that abono totally deductible from income. And that will be a game changer. Whether big corporations, kasi ngayon sa Internal Revenue Code may limit eh. You can only donate so much, 3%. After that, wala na. And so they give to big advertising campaigns where the name of the corporation is in basketball or whatever. Pero yung needs of the country, hindi nami-meet. Health and education should be free, as in first world countries. Pero kung hindi natin magawang libre, at least make it tax deductible to the full. Whether it is income tax, whether it is corporate tax. And so we change the game. And so after this, I would suggest a small group that will think of ways of funding the requirements for health. Thank you.
Thank you, sir. I'd like to make a comment on that. Sa amin po sa foundation, we're finding that more people are open to giving. It's just that restrictive yung laws when it comes to tax breaks that they would get. Kung kaya parang napipigilan silang magbigay ng mas malaki kasi hindi naman ganun kalaki din yung nagiging tax break sa kanila. Kung sana makapartner natin ang ating BIR sa pagpapaluwag para maging mas open yung mga generous na organizations, companies, individuals to support yung mga ganitong pangangailangan ng ating mga mahihirap. Tama din po kayo, Sir Evie, I always say, ang kalusugan ay hindi pribilehiyo, dapat karapatan. Kasi kung marami din po kami mga nakasalubong bansa sa mga summit and conferences, nakakalungkot na tayo ay dating nangunguna sa Southeast Asia, pero nauungusan tayo ng mga bansang kagaya ng Malaysia, ng Indonesia, Thailand, in terms of cancer care. Kasi sa kanila, even India, na ang laki ng population nila, pero kapag may cancer, pasok lang sila sa public hospital, wala silang iintindihin, libre lahat. So sana ganito din tayo ka-proactive sa paggawa ng mga solusyon para maging mas accessible at mas maraming mahihirap. Kasi alam naman natin ang realidad. Ang mga programa ng gobyerno ay talagang kailangan ng ating mga mahihirap. Ang mga programa na kahit yung mga makabagong mga development sa gamutan, natutuwa ako every time na may bagong gamot na epektibo naman at talagang nakakatulong sa mga pasyente. Mas maganda siyang pakinggan. Pero alam ko na hindi po ito mapapakinabangan ng mga pasyenteng pinagsisilbihan namin dahil mahal, hindi siya kaya. So, sana kung magagawa ng paraan na alam din po namin na may mga malalaking pharmaceutical company who are willing to partner with the government to provide their medicines to make it more sociable at a cost na kikita pa rin sila pero nakakatulong sila sa mahirap. Kung makaka-create tayo ng ganong synergy, why not? Makikinabang ang ating mga mas nakararaming mahihirap.
I think at the end of the day, it really reflects na how we treat cancer. It's really, it takes a village to treat it. Now, basically, on the medical side, hindi lang naman medical oncologists ang gumagamot, no? May surgeons, may radiation. Multidisciplinary yung tawag namin. And again, when you look at it at the bigger context, the social determinants of health, there are other stakeholders, no? The lawmakers, the government, even the private organization. So I think it really takes like one goal at magkakasamang cumulative effort from everyone. If really want to make this work. And siguro like just to add to Miss Eileen's yung experience nyo, yung interacting with other countries. Actually, to be honest, no, when I also interact with my colleagues from other countries, hindi na ako titingin, hindi na tayo sa Western kasi definitely given na yun. Kahit among our neighboring countries, I had to explain to them na out of pocket ang Philippines in terms of healthcare. So I have to parang nagugulat sila na, so it's not subsidized.
Mataas ang out-of-pocket cost.
So I have to explain to them countries from Asia, from our neighboring countries na ganito po yung... So parang sila, I think you can see in their faces na parang kino-compute din nila yung, so ito yung kinispend ng isang tao for ano. So I think it's about high time. And I'm very hopeful, of course, with the cancer, no? And I think I'd like to think that we're moving into that direction. Na ultimately, kasi at the end of the day, it's for the Filipino cancer patient.
At saka naniniwala ako, may pondo eh. Hindi lang namamanage ng tama, hindi lang nagagamit ng maayos.
Maraming pondo, maraming basketball court na natatayo eh.
Sana, di ba, kung na-fund sana yung ilang mammogram or ilang test sana. So again, yun yan, no, parang maging, or ilang beses pinanturahan yung kalsada. I mean, binungkal yung kalsada, binungkal. So I think, you know, kung kumbaga parang second nature na lang na, nga yung health, dapat part talaga siya ng mga program natin, even in the LG or local level.
At sa mas madali ang tanaw po, dapat siguro kailangan na nating seryosohin na dumadami ang cases ng cancer na hindi na ito pwedeng, there's a big white elephant in the room and we need to address it. Hindi na natin siya pwedeng, hindi tayo pwedeng magpanggap na hindi natin nakikita magbubulag-bulagan. Kasi eventually po, talagang magkakaroon talaga ng epidemic levels.
WHO na yung nag-warn
yes.
Epidemic level ang inaasahan natin for cancer. I think we have 2 more questions. Down to our last 2 questions.
Hi, morning, Mads po from Net 25. Kanina may mga binabanggit po kayong bagong gamot na effective sana, sayang hindi makapasok sa program po ng gobyerno. Ano po yung challenges? Bakit mahirap pumasok sa Philippine formulary?
Yung kanina nga po, no, parang for example, kailangan siyang i-review. So yung review it's a stringent, it's a long process. There are a lot of experts that are coming in para to review the medications before they are included in the formulary. So yun yung challenge, no? So
at saka matagal. Yung proseso matagal.
Parang alam na namin na, for example, itong si drug A, ginamit na to sa ibang bansa, approved na ng FDA, hindi na ginagamit na nila. So kasi sa ibang bansa kanila, for example, for US, kasi FDA approved, okay na yan sa HMO, sa ano nila. So wala nang problem, wala nang titigil sa kanila. So even if we know that the drug really works, dito sa atin, before sila ma-include doon sa formulary na national formulary natin, para, yung first step, para ma-acquire, pwede siyang i-acquire ng DOH as free. So doon naging roadblock yung pag-review ng medications. No, kailangan mo na siyang i-review before included into the formulary. And sabi nga ni Ma'am Aileen, it's usually a long process. But hopefully, since I think the government or they recognized it, they're now, I think, including or they're now onboarding more experts now. So I'm keeping my fingers crossed. It will
Sana
be
may
fixed.
sense of urgency. Oo. Siguro ang nakikita, huwag natin baguhin kasi importante din na stringent yung process. Pabilisin lang natin. Yun ang mahalaga. Pabilisin natin para yung essential life-saving medicines ay maging available na agad para sa ating mga kababayan.
Okay, our final question.
Yeah. At Santos po from Daily Tribune. Sir, ma'am, ang gusto ko lang malaman, yung buong bansa, apart lang, tatlong, Luzon, Visayas, Mindanao, yung mga LGU na hospital available, kaya ba nila yung skin diagnostic, malaman lang ng person na may ano siya, kaya ho ba sa tingin nyo ngayon sa setup ng do we have enough oncologists sa buong bansa? Gano'n po ba karami lang kayo?
Okay. So, napag-usapan din namin ito kanina. No? When you think about it, we're about 100+ million Filipinos already. The oncologists all over the Philippines is around 300. 300 only. That's for the whole of Philippines. And admittedly, metro-centric. Majority are here in the metro. So doon pa lang medyo ano. So actually, the institution where I came from, we really try as much as possible to get oncologists, to get trainees na pupunta sa institution namin at magte-train at babalik sa kanila. No? And may mga okay na mga LGUs and mga municipalities na parang nagsisend sila ng scholars nila. Na-train namin kasi babalik sila, parang balik provincials sa community nila. So, currently, I think more than anything else, infrastructure-wise, so I guess, sabi ko nga po, ang pag-treat ng cancer, multifactorial siya, no? Manpower, kailangan mo ng oncologists, kailangan mo ng tao, nurses, surgeons, kailangan mo na rin naman ng equipment kasi pang-diagnose. And of course, kailangan mo ng gamot ultimately, no? So, may medyo challenging siya. Siguro ang isa sa mga naisip kasi we were also brainstorming before how can we do it. Baka mahirap kasi na talagang to do it in every single LGU. But probably ang isang magandang model is what we're looking at is a hub and spokes model. Like a centralized referral. Like for example, of course, I'll use probably in Mindanao, and we were talking about SPMC, Southern Philippines, it's a huge hospital in government hospital in Davao, very well equipped. I have my colleagues there, radiation therapy, we had onco-surgeon, everyone is there. So, of course, it would be challenging, it would be very costly kung i-replicate mo siya sa lahat. But probably, ang magandang gawin dun is parang hub and spokes model, like coordinate with the nearby, probably primary or secondary
or at least at the regional level, though.
At least at the regional level. And then, for example, may patient na nagpunta, may nasalat na bukol sa suso, tapos highly suspicious na to of malignancy. Siguro na, baka at the secondary hospital level, baka na biopsy na. Kumbaga yung connection, yung highway, may good referral system na. Of course, may limitations yung secondary hospital, baka hindi nila kasi wala rin sa kanila yung pondo for the medication. So, I think yun yung baka mas feasible at baka mas kaya pa natin at this point. Ideally, syempre, yung lahat ng LGU are equipped. But baka for now, yung ganun yung parang referral hub and spokes model, yung baka mas feasible.
Sa mas maliit na pananaw, siguro isa ding bagay na dapat pagtuunan is maka-encourage tayo ng makapag-train ng experts like oncologists, pathologists, and the whole multidisciplinary team. Sana meron tayong mga eskwelahan. Sana yung ating mga kabataan ay pwedeng makapag-aral para maging dalubhasa sa mga areas of cancer na kakailanganin sila na hindi ganun kabigat so that we can have more experts who will take care of all the needs all over the country. So we can have more pathologists. Kasi ang nakikita ko po madalas, ang funding na pupunta sa building the infrastructure, pero hindi na pagtutuunan ng pansin na kailangan mo dyan ng mga tao. Wala na, meron kang cancer center, wala namang oncologist, wala namang surgeon, wala namang pathologist, wala namang radio technician, wala namang mammotech para mag-operate ng mammogram. So build lang tayo ng mga structures at saka ng mga nag-i-equip ng mga machines, pero wala yung mga experts, yung technical expert na magagamit doon para maging kompleto naman yung care na maibibigay natin. So ito siguro isa sa mga aspeto na dapat natin tingnan. Kumusta ang ating medical schools? Kaya ba nating magbigay ng mas maraming scholar na mag-aaral para maging doktor, maging oncologist, maging surgeon, maging magaling na medtech, maging magaling na pathologist? Yung mga bagay na to po. Hindi lang kasi ito yung parang usaping cancer lang within diagnostics and treatments. Ang lawak ng ating gagalawan. Malaki yung ating kailangang tignan.
Okay, I think on that note, we can end our discussion. Maraming dapat gawin. Hindi lang isang grupo ang makaka-solve ng problems natin. We thank our media partners who attended this Kapihan ng Samahang Plaridel today. Maraming salamat kay Dr. Kenneth SAMALA, kay Ms. ANTOLIN, and kay Madeline, who also joined us here on stage. Thank you so much, and until our next forum. Those who want to go, need to do after on your own. Go ahead.